Okay, before we go ahead and get started with the review of the exam that I gave you, the practice exam, are there any other questions in general that you have or want to ask before we start into those questions? Okay, question? Well, alveolar dead space is part of physiologic dead space. Remember, physiologic dead space is the anatomical dead space, which is your upper airway, and alveolar dead space is any alveoli that's being ventilated but does not have perfusion. Therefore, it's not involved in gas exchange. The combination of those two are physiologic dead space, and that you have to subtract from total ventilation to calculate alveolar ventilation. Okay, so does that answer your question? So make sure you keep in mind, that all dead space is not involved in gas exchange, so therefore is not part of alveolar ventilation. Other questions? Sure. Well, when we refer to emphysema with regard to sleep apnea, remember, sleep apnea is where your mechanisms, your control mechanisms, are not functioning properly. Remember, under normal conditions, breath to breath is regulated by your central chemoreceptors and the partial pressure of CO2. So under normal conditions, you breathe very rhythmically based on this feedback loop and mechanism. So when it doesn't function properly, and we talked about certain instances where sleep apnea or the mechanism doesn't work, where we become desensitized to the partial pressure of CO2 in the central chemoreceptors. So if you have chronic exposure to high CO2, those receptors become desensitized, they don't respond readily, and there's a big delay in their response, and it takes bigger swings of the partial pressure of CO2 to regulate respiration. And as we talked about advancing emphysema, we have such a difficult time exhaling, therefore our CO2 climbs, and we have a high CO2 exposure. Therefore, we become apneic, or we get apnea because the CO2 is not regulating it. Okay, so chronic exposure to high CO2 and emphysema desensitizes our central chemoreceptors to partial pressure of CO2. And hence, sleep apnea is also quite common. And sleep apnea in general has a variety of different causes, but quite often it's a chronic respiratory disease in those people that suffer sleep apnea. Question? Yes. The best way is to put that up. Do you remember what lecture that was in? It was 3 or 4? Yeah. I'm not sure if it was. There. Okay, now, I really do want you to... Oh, that ain't going to work, is it? Projector on. I want you to understand this curve. This is a curve where we're looking at the pressure of the chest wall relative to the pressure of the lung, and it's a combination of the addition of both of these pressures that give us our pressure of the respiratory system. So make sure you understand this curve, which will be up here in just a moment. And remember, the chest wall is sometimes working in opposition to the recoil of the lung, and sometimes it's working with the pressure of the lung. So when we look at this curve, we're going to define what those points are. And there we are. So in this case, the easiest place to start is when we look at the pressure of the lung. Remember, the pressure of the lung is always in one direction. It's always recoiling. So it always has a recoil pressure. We call that a positive pressure. So as we increase volume, or in this case it's percent vital capacity, but as we increase volume, in other words, as the lung stretches, it has more recoil force. So you can see that the pressure increases as we increase volume. Okay, so that's to easily explain the lung. So the lung always wants to recoil, no matter what volume we're at. Even if you go all the way down to residual volume, which you see at the bottom, this volume, we still have a positive pressure. In other words, it still wants to collapse and go in one direction. So that the lung is very easy and straightforward to understand that. However, when we talk about the chest wall wants to go the opposite direction, especially at low volumes. At low volumes, it wants to move outward. Remember, lung wants to move inward, chest wall wants to move outward. So you can see that's a negative pressure relative to the lung. So at low volumes, they're in opposite directions. They become equal and opposite when we get to functional residual capacity, which is at end expiration. So at that point, remember, as you sit there and you passively exhale, all the muscles and all the forces come to an equilibrium. You have no added forces, so it's just an equilibrium. And at that point, the lung still wants to collapse, the chest wall still wants to move out, but because they're equal and opposite, all motion stops. All right, so that's what the total respiratory system is. That's this line in the middle. So it reaches zero pressure when these are equal and opposite. Now, as we increase volume or vital capacity, either way, we increase. So now our chest wall is moving more outward because we're increasing volume. And as we do that, we approach the neutral point for the chest wall. This is where the chest wall has no more elastic force going in either direction. So it reaches its happy point or its neutral point where there's no muscle strain. So at this point, where this is zero, the pressure of the lung is equal to the total respiratory pressure, because pressure of the lung plus the pressure of the chest wall, which is zero, is equal to the pressure of the lung, which is the total respiratory system. So these are equal at the point where the chest wall is equal to zero. All right, so that makes sense. So now at this point, now the chest wall, as we still increase volume, now goes the other direction. We keep expanding. Now the chest wall wants to move inward. So now chest wall wants to move inward, lung wants to move inward. This is where the total respiratory system becomes even greater positive. So now they're working with each other as opposed to against each other. So make sure you understand this curve. Now, an important point I want to make here is this equal pressure point for the chest wall is above our normal inspiratory volume. So as you sit there at rest and you inspire a normal tidal volume, you are below this number. Okay? You're somewhere down in this area. So under normal resting, ventilation, the chest wall always wants to move outward, the lung wants to move inward. Only when we go to greater ventilation, greater tidal volumes, does the chest wall move across this line and then want to move the same direction. All right, so make sure you understand where these different points are. FRC, where an normal end inspiration at rest is, and also where the chest wall reaches a neutral point. Okay, that should hopefully explain that. Question? Why does it want to move inward? Because the elastic forces. As you take your chest wall and your muscles pull it outward, you pull it outward to a point where now it wants to recoil inward. That's just the ligaments, the bone, etc., wanting to come back in. And where at the lower volumes, it wants to move outward. It's just all the elastic forces pushing and pulling. Question? Yes. That was in the same lecture, wasn't it? Up here. There it is. Okay, when we talked about filtration reabsorption, first we talked about the systemic circulation. Systemic circulation is a high pressure system. At the capillary bed, the pressure is much lower because as it goes toward the venous, we get a very low pressure. So the capillary bed is kind of in between the arterial and the venous circulation, so it's much lower than your normal central arterial pressure. But either way, we look at the capillary pressure at 32 millimeters of mercury. Remember, oncotic, so capillary pressure is basically your blood pressure. That's the pressure or the hydrostatic forces that are pushing outward due to the pressure within the vasculature. The oncotic pressure is a little more difficult to understand. It basically depends upon the amount of proteins, the concentration of proteins in that interstitial space, and it holds water associated with those proteins and therefore creates a interstitial pressure. So normally in a systemic circulation in the capillary bed, the pressure inside is greater than the pressure outside initially, and fluid moves into the interstitial space. But as we get toward the venous system, now we start to get reabsorption because now the pressure drops low enough, it drops below the oncotic pressure, so now we get reabsorption. However, in the pulmonary system, because it is such a low pressure system, now when we look at the capillary pressures, they're even much lower than the systemic capillary pressures. And in this case, the capillary pressures, the hydrostatic pressures, are always lower than the interstitial pressures. See, here they're half the pressure, so they're substantially lower. And by the time we get to the other end, they're greatly lower. So we get nothing but reabsorption of fluid throughout the capillary bed of the pulmonary circulation. So that's just how we keep the lungs dry. We keep that interstitial space with as minimal fluid in it. Okay, so the importance of that is to maintain that minimal fluid so that we can have good gas diffusion. Because if we get too much fluid in there, it impedes gas diffusion, as we've talked about in pulmonary edema. Any other questions? All right, we'll go to the practice exam. And even during the practice exam, if you have any other general questions, feel free to just speak up and ask as we go. Yes?
When we exhale, the airway will dilate, so the diameter can rise, but also the it couldn't get into the turbine air port, so the resistance can be up. So when diameter goes up, the resistance
Well, essentially when we inhale, the airways are pulled open. So there's low resistance during inhalation. So we very seldom have an increase in resistance during inhalation. Most resistance problems, even associated with disease, are during exhalation. Exhalation is where we change our forces, and if we do passive exhalation, typically still not a problem unless we have physical obstruction, mucus accumulation, etc. But you're referring more to the equal pressure point when we're talking about disease and forced exhalations. Now, in a forced exhalation, that's where we have a positive pleural pressure. So that positive pleural pressure is pushing on the lung. And so if the pressure within the airway is lower than the pleural pressure, we get collapse of those bronchioles, which are not surrounded by cartilage. And as far as turbulent flow is more likely to occur in larger airways than it is smaller airways. So we have more turbulent flow in the trachea, per se, than we do down in the lower vessels. So turbulent flow really isn't going to come into play unless we start talking about changes in viscosity. We talked about the Reynolds number, and as far as Reynolds number, all we really cared about is, for most of all, the larger the diameter, the more likely you're going to have turbulent flow. And what was the other parameter? Velocity. Okay, so the faster it's moving, the more likely you're going to have turbulent flow. Okay, and we know also in the trachea, the velocity is faster because of total cross-sectional area. So be careful about, well, in this case, when we're talking about velocity and turbulence, it's not total cross-sectional area that's important, but it's the individual diameter, as you mentioned. So as you increase the diameter, more likely to have turbulence. Decrease the diameter, less turbulence. But that's how, a doctor puts a stethoscope on your back and they listen, because if turbulence gives sound and laminar flow gives no sound. Okay? So hopefully that kind of helped explain that a little bit, but it is somewhat complicated. Now, our practice exam was this one. I guess I could put up your exam, and then we could just go right through that, right? I don't know. Going through those questions earlier, I'm not sure how many of you would pay attention and actually be able to, repeat those answers. It is a little concerning sometimes. Okay, now this is an old exam. Actually, I didn't write this exam, so there's a couple little quirks in here about some of the numbers. They didn't come through very well, and I don't even understand what they were supposed to be. But we'll start. You want to just ask general questions to skip around, or you want to just go through the whole thing? All right. We should have enough time. Number 1. Which of the following will decrease blood flow? Now remember, blood flow is called perfusion through the lungs. So what will decrease blood flow through the lungs? A decrease in pulmonary vascular resistance. Now, if we decrease it, that means blood flows more easily, and if anything, will increase blood flow. A decrease in the arterial to venous pressure gradient. Now remember, the arterial to venous pressure gradient is directly proportional to flow. So if we increase that gradient, we increase flow. If we decrease that gradient, we decrease flow. So that's why if we decrease this gradient, we decrease flow. And an increase in blood pressure within the pulmonary artery. Now, if we increase blood pressure, if anything, that's going to increase this gradient, not decrease it. So if we increase the gradient, we increase flow. All right. Number 2, in a person with emphysema, residual volume increases because of a decrease in lung compliance. Well, it's true that residual volume increases, but not because of a decrease in lung compliance, because in emphysema we have an increase in lung compliance. Here, residual volume increases due to flow limitation that causes air trapping. And this is what we talked about just a moment ago as well when we talk about emphysema. Remember, We have poor recoil of the lung, therefore we have to use forced exhalation to push the air out. In other words, we're creating an active expiration which causes a positive pleural pressure. The positive pleural pressure pushes on the airways, so mostly when the lung volume starts to get smaller, the airway pressure decreases, therefore the pleural pressure overcomes the airway pressure and causes collapse, therefore trapping air within the air spaces. Okay, so that is our correct answer. FRC increases because of an increase in lung recoil pressure. If we have an increase in lung recoil pressure, FRC would decrease, first of all. Okay? Question 3. Now, is there any question about the equal pressure point, the collapse? Remember, it's only going to occur during an active expiration. Because as long as we have a negative pleural pressure, we're not going to exceed that of the airway pressure, because the airway pressure can only go to 0. All right? Or a very low negative number. So we're really not going to exceed the airway pressure under normal conditions if we do passive expiration. Only active expiration will do so. Now here, in a person whose spinal cord is severed at the level of C7, we talked about this early on when we talked about the anatomy, where the different nerves come off. And mostly when we're talking about spinal cord injury, we were only talking primarily about the somatic neurons, the ones that regulate the diaphragm, the intercostal muscles, the external intercostal muscles. So we primarily just in reference to those. So remember, C7 is actually fairly low. So we're going to lose everything below that. But because it's a little lower, we're going to maintain some ventilatory patterns. Now remember, it was C3 through 5 or so that regulates the phrenic nerve, which is the diaphragm. So we're going to lose the diaphragm. No, I'm sorry. The diaphragm is in the upper right, the top. So we're going to lose everything below that, which was the intercostal and external intercostal muscles. So the intercostal muscles are what we're going to lose. So in that case, sever there, we're going to lose some inspiratory effort, and we're going to lose some forced expiratory effort. So inspiration will be completely normal, not true. Expiration will occur primarily via passive recoil of the chest wall. Well, it does typically anyway, but now if we do a forced exhalation, then it will be slightly decreased. So that one's a little tentative, but the ability to cough will be decreased. Remember, coughing primarily comes from your diaphragm, but also if your internal intercostal muscles, all of your expiratory muscles are involved in a cough. So when you cough, all of your expiratory muscles contract at once and gives you that forceful cough. So if we lose the intercostal muscles, we still have the diaphragm, which is going to be the bigger portion of it, but we're still going to decrease considerably our ability to cough. Okay? So remember on the exam, it says pick the best answer. So even though this answer might work, this is by far the best answer. Okay? So make sure you keep that in reference. Number 4, in a person with pulmonary fibrosis, expired ventilation must increase in order to maintain normal alveolar ventilation. Now, if you have pulmonary fibrosis, the first thing that you got to think about is your tidal volumes are going to be small. Okay, so if you're going to decrease your tidal volume due to the fibrosis because you can't expand the lung normally. So in this case, expired ventilation must be increased in order to maintain normal alveolar ventilations. So a normal alveolar ventilation is dependent upon that tidal volume. And if we decrease the tidal volume, what are we going to have to do? We're going to have to increase rate. And if we increase rate, relative to tidal volume, at the same total ventilation, we decrease alveolar ventilation. So in order to maintain alveolar ventilation, we're going to have to increase total ventilation. Okay, so this is a very involved answer right here. So you have to think through it. So in this case, this is all true. We have to increase total ventilation to maintain a normal alveolar ventilation because tidal volume is decreased. Does everybody follow that? Okay, because make sure you really understand the relationships between alveolar ventilation and total pulmonary ventilation and how dependent upon rate versus tidal volume. Because if you increase rate, you increase dead space. Because every time you take a breath, dead space is involved. If you increase just tidal volume, that does not change dead space because now you're still using the same dead space and the extra tidal volume goes to alveolar ventilation. Okay, so make sure you remember that relationship because that's what we're referring to here. As well, diffusion of oxygen across the alveolar capillary membrane decreases. That's true because the thickness increases with fibrosis. FRC decreases because lung recoil pressure decreases. Okay, so this lung recoil pressure remains the same. It doesn't really change. Remember we talked about elastance? Even in fibrosis, elastance is fairly normal. We aren't affecting the elastic fibers. They're still present. It will still recoil. However, in emphysema, we affect elastance as well as compliance. So D is the answer. Sure. What was that again? We get an increase in FRC in emphysema. Right, we would get a decrease in FRC in fibrosis. So that part of it's correct. Right, there's a decrease in FRC, but not because of the recoil pressure decreasing. Okay, that's because we decrease our tidal volume. Okay, number 5. In a person with a pulmonary embolism, remember pulmonary embolism is a blood clot. Alveolar dead space increases. Okay, we talked about this. This is true. So if we have a blood clot, we have no blood flow, but we have the alveoli being ventilated. Therefore, that's alveolar dead space. The VQ ratio decreases. Well, as we know, perfusion decreases, so this ratio is going to increase. The pressure of the airway increases. Pulmonary embolism has nothing to do with airway pressure. Only A and B are correct, so A is your correct answer. Number 6, the alveolar oxygen is less than the inspired oxygen because, and as we know this is true, inspired oxygen, if you calculate it out at sea level, is about 160 millimeters of mercury. That's our inspired oxygen. And we know that our alveolar oxygen is normally about 100 millimeters of mercury. So we know there's a difference between those. We know that alveolar oxygen is lower than inspired. And the reason why is multifold. Water vapor pressure increases during inspiration. So if you take atmospheric gas, is not always 100% humidified, but it is by the time it gets to the alveoli. So you have to subtract water humidity from total barometric pressure when you're calculating the partial pressures. So therefore, the partial pressure of oxygen is less because you have to subtract more water vapor pressure. Okay, so water vapor, it comes into play, as well as oxygen is constantly diffusing into the pulmonary capillaries. So we're consuming oxygen. Therefore, oxygen is lower in the alveoli because we draw it off and consume it. The PaCO2 is greater than the PIM, which I don't even know what that was. supposedly that was true, but we'll ignore that for the moment. So A and B are correct. That should be fairly straightforward. Number 7, partial pressure of arterial oxygen will be less than normal if. So less than normal. And we know that normal is about 100 millimeters of mercury. What will cause that to be decreased? And this abbreviation here is talking about diffusion across the membrane. So the diffusion across the membrane decreases. That is true. If we have less diffusion, arterial oxygen will be less. Alveolar dead space increases. So if we increase alveolar dead space, that means we have no perfusion. Therefore, we're going to decrease, once again, the amount of oxygen that diffuses across, and that's going to also decrease. A shunt increases. Now, if we increase a shunt, once again, we said that's unoxygenated blood, therefore our PaO2 will also decrease. So all of these are true. Remember, that's Fick's law when we're talking about diffusion. Remember Fick's law. Distance, pressure gradient, thickness. Number 8, which of the following statements is false in the conducting zone airways? The sol layer is maintained by the movement of ions and fluid across the apical membrane of the ciliated epithelial cells. Remember, the chloride channel is very important for initiating the movement of ions and fluid into that ciliated space, creating this sol layer. That's true. Airway smooth muscle contracts when acetylcholine is released from parasympathetic neurons. Remember, we talked about the nerve regulation, and it's the parasympathetic system secreting acetylcholine that constricts smooth muscle cells of the airways. That's true. Only sympathetic neurons innervate the subepithelial mucus glands. That's false. Remember, these mucus glands are innervated by both the sympathetic and the parasympathetic, so they have balancing inputs. So they can increase or decrease mucus production. In this case, it's the parasympathetic neurons that will cause an increase in mucus gland secretion, and it's the sympathetic that will cause a decrease. Okay, and gas exchange does not occur in these airways, which is true. Prolonged cigarette smoking decreases movement of cilia and causes an increase in the number of goblet cells. That's true. So remember, it slows down cilia and also increases the amount of mucus being produced. Number 9, the overall VQ ratio of the lung can be altered by changes in alveolar dead space, which is true, therefore we're decreasing perfusion, so that'll affect the ratio. Changes in the amount of extrapulmonary shunt. Well, of course, that once again, the more shunt, the less oxygenation, the less blood flow. So if we're shunting the blood outside the lung, that means it's not going through the lungs, so we decrease Q. Moving from standing to the lying down position. Remember, we said as you stand, you're very gravity dependent. The VQ ratio is dependent upon where that sits. So if we move from standing to sitting, that can certainly also change, or standing to laying down. Okay, it redistributes that altogether. So now we get a completely different distribution of ventilation and perfusion. So all 3 of those were true. Number 10. Which of the following statements is false with regard to the diffusion of oxygen across the alveolar capillary membrane? At rest, most of the diffusion occurs within the first 1/3 of the pulmonary capillary. which we talked about, blood transit time, the diffusion capacity of oxygen versus CO2. And in this regard, remember, oxygen still comes to an equilibrium very early in that transit time, so it's very fast. But CO2 is even faster. So if it would be 1/3 for the oxygen, it would be a fraction of that for CO2. During exercise, diffusion of oxygen across the lung increases due to recruitment of pulmonary capillaries. That is true. Remember, we have a high capacitance within our lung and the ability to take up the increased cardiac output when we exercise without increasing pressure. Very important. So we have a high capacitance of the pulmonary circulation, so it recruits pulmonary capillaries. They dilate without increasing pressure. The diffusion of oxygen in the lung can be measured directly by having you inhale air with different FiO2s, or partial pressures of inspired oxygen. That is not true. We cannot do that. Remember, to measure diffusion, we use something that does not cross the membrane very easily, as like carbon monoxide. We use that as a control, but we use like 0.1%, so very small amounts so that we don't come into carbon monoxide poisoning, but it can be used as a diagnostic tool to calculate diffusion, but you cannot use oxygen. The oxygen diffusion will increase if the partial pressure of inspired oxygen increases. And we know that that is true because we increase the gradient, the pressure gradient, so that therefore we increase diffusion. If the diffusion across the lung of carbon monoxide increases, then the diffusion of oxygen will increase. And that's true because carbon monoxide is what we use to calculate a diffusion number, and if we increase the rate of diffusion of carbon monoxide, that is directly proportional to an increase in diffusion of oxygen as well. Number 11, the partial pressure of oxygen in the pulmonary veins is, first, when you read the question, before you look at the answers, make sure you understand the question. Now, we're talking about the pulmonary veins. The pulmonary veins are where? They're postcapillary, okay? In this case, pulmonary veins are oxygenated blood. So once the pulmonary blood is oxygenated, the partial pressure is equal to 100 millimeters of mercury in a normal individual. Less than 100 in a person with an extrapulmonary shunt. Well, that would be true also. Because remember, a shunt decreases the amount of oxygenation, therefore this would decrease. Greater than 100 if the inspired oxygen increases to 250 millimeters of mercury in a normal individual. Remember, the inspired oxygen typically is about 160. All right? So if we go to 250, that's a pretty good increase. Then we will increase the alveolar partial pressure, and that is in equilibrium with the arterial partial pressure. So therefore, yes, it will increase. So all of those are true. Number 12, which of the following will decrease the oxygen carrying capacity of hemoglobin in venous blood? Once again, when we're talking about oxygen carrying capacity of hemoglobin, we're talking about oxygen hemoglobin dissociation curves. Okay? So what is going to decrease the carrying capacity? So if we decrease the carrying capacity, that means we decrease the affinity, we make the oxygen more available, and therefore that's shifting the curve to the right. All right? So make sure you understand that when you read the question. So now they're asking basically what's going to shift that oxygen hemoglobin dissociation curve to the right? A decrease in oxygen, that shifts it to the right. Remember, we talked about the relationship of the effect of CO2. The effect of CO2 is greater if we have hypoxia. So also hypoxia. Hypoxia means that we need more oxygen. Anything that causes a need in oxygen demand means that we're going to shift the curve to the right. An increase in the PCO2. Well, that would be true also because, once again, metabolism produces CO2, increased oxygen demand, higher CO2 shifts the curve to the right. An increase in hydrogen ion, that means it's more acidic. We decrease the pH. That also shifts the curve to the right. So all of those are true. (13) As blood moves through the pulmonary capillaries, the bicarbonate concentration decreases. That is true. So as the blood moves through the pulmonary capillaries, that means we're moving CO2 out into the alveoli. So as we move CO2 out, remember, the bicarbonate is converted back to CO2, therefore the bicarbonate's decreasing. The amount of dissolved CO2 decreases, which is also true because that's what's directly diffusing into the alveoli. The amount of hemoglobin carbon dioxide increases. No, because that's going to also decrease. Because everything, as CO2 leaves, CO2 comes off of the hemoglobin, it comes back from the bicarbonate, and it comes from the dissolved plasma concentrations. So A and B are correct. 14, in a person with emphysema, an increase in the inspired oxygen may cause all of the following except. So if we increase oxygen, inspired oxygen, which patients with emphysema often have oxygen therapy, a decrease in hypoxic pulmonary vasoconstriction, because remember we said emphysema patients quite often have a chronic hypoxia. Therefore, if we give oxygen, we will not have a hypoxic pulmonary vasoconstriction, so that will decrease. An increase in the PaO2, yes, because we're going to increase diffusion, so we will increase the PaO2. An increase in the diffusion of oxygen, yes, because we increased the gradient. So we increase the partial pressure in the alveoli, therefore the gradient is going to push more oxygen across, therefore diffusion will increase. An increase in the number of alveoli. Well, that's false because we know in emphysema we have a decrease in number of alveoli. As well, decrease the thickness of the alveoli capillary membranes. Which in essence, in emphysema, there is a decrease in thickness because what happens from the deterioration and degradation of the alveoli, they deteriorate, and hence they actually do thin a little bit. And in that essence, it would actually also increase diffusion. Okay, so all of those are true. It's D that's the exception. 15. In a normal individual at sea level, all the following occur during exercise except recruitment of the pulmonary capillaries, which we previously mentioned, an increase in the surface area of the alveoli. As you're exercising, you increase your tidal volume. You breathe at a higher volume, therefore you're increasing the surface area. A marked increase in the concentration of oxygen in the arterial circulation. This is the exception. This is not true. Content. Remember, at rest, your content is pretty much maximized. You are 100% saturated of your hemoglobin, very close to 100%. You can't go more than 100%, okay? 100% is 100%. The amount of oxygen that dissolves in plasma is so minimal. Remember, it's less than 2% of your total content. So you aren't going to change that hardly at all. So therefore, you are not going to have a marked increase in oxygen content when you exercise. Even though we're consuming more, but we're also bringing more in because we increase our alveolar ventilation. So once again, it stays pretty similar. So you have that very tiny increase due to the increase in partial pressure. but that's less than 2%. So that's why it says a marked increase. So it's a very tiny increase, if at all. An increase in the oxygen driving pressure across the lung, that is true, because remember, we increase alveolar ventilation, we increase the partial pressure of oxygen in the alveoli. An increase in the diffusion of oxygen across the membrane. That is also true because if we increase the partial pressure of alveolar oxygen, we increase the pressure gradient once again, and also we're consuming a lot of oxygen, so we're actually lowering the partial pressure of oxygen in the arterial circulation. Once again, increasing the pressure gradient so we have better diffusion. 16, after prolonged exposure to high altitude, so several weeks, the content of oxygen returns toward normal. It doesn't say it's normal, but it's moving toward normal. And the reason for that is because the hemoglobin concentration's increasing. Remember, chronic hypoxia, altitude will cause the increase in hemoglobin production through erythropoietin. So therefore, we have a higher carrying capacity, so the content of oxygen will increase because we have more hemoglobin. Oxygen saturation of hemoglobin returns to normal. That is not true. Now remember, saturation is dependent upon the partial pressure of oxygen. Now if we're at altitude and we don't move from there, we're not going to change the partial pressure. Partial pressure is going to remain what it is. Therefore, saturation of the hemoglobin is dependent upon partial pressure. If we take our partial pressure below 100, just look at the curve. You can see the saturation decreases as the oxygen decreases. So if we go below 100, then that will also decrease. All right, so A and B are correct. Erythropoietin, which we just mentioned about. Yes, question.
For that question, what about after returning to normal altitude? Let us see. Like after being at high altitude for a while, then returning to lower altitudes after that period.
Saturation will return to normal quickly. Okay, that'll be a real quick response because it's directly dependent upon your FiO2, your inspired oxygen. So if your inspired oxygen is normal, immediately your saturation will reflect that. Yep. Erythropoietin, as we just talked about, increases due to a decrease in PaCO2. That is not true. So it's dependent upon oxygen. Remember, it's hypoxia that causes changes in erythropoietin, not CO2. Increase the number of red blood cells. That is true. Increases the amount of dissolved oxygen. Has nothing to do with dissolved oxygen. Remember, that's partial pressure. Partial pressure is not regulated by content. Content is mostly determined by how many binding sites do we have for oxygen. So B is the correct answer. 18, carbon monoxide poisoning. Remember, in carbon monoxide, we said has an extremely high affinity for hemoglobin, much higher than oxygen. Therefore, it's competitive with oxygen, so it will force oxygen off the hemoglobin. If you remember in your biochemistry, when you talk about any binding affinities, most of those are in an equilibrium and such that they bind, they unbind, they bind, they unbind. So they're always binding and unbinding at a particular rate. Oxygen binds and unbinds much more readily than carbon monoxide. So as oxygen temporarily unbinds, carbon monoxide quickly fills in and binds and then doesn't come off near as often. So we certainly, it forces its competitive binding with hemoglobin and oxygen. Requires a large decrease in PO2 to dissociate just one molecule of oxygen from hemoglobin. This was the example we gave when we said we had carbon monoxide poisoning that covered 50% of the hemoglobin sites. Remember, carbon monoxide increases the affinity of hemoglobin for oxygen. So now oxygen comes off more difficult than it would normally. And can be treated in a hyperbaric chamber. That's true. Remember, that increases the partial pressure, and especially if you're breathing 100% oxygen. Now your competition with carbon monoxide becomes competitive. So oxygen can now compete for carbon monoxide, those sites that carbon monoxide is bound, and eventually you can get rid of that carbon monoxide because you have 100% oxygen at high barometric pressure. Therefore, it's so high of a partial pressure of oxygen, it does compete and drive it off. Which one? B? Yes, and that was in that one diagram that as I mentioned when we talked about carbon monoxide poisoning. Carbon monoxide, when it binds to hemoglobin, alters the conformation of the hemoglobin molecule such that any oxygens that are bound also to that hemoglobin are now bound tighter. So if they're bound tighter, that means they come off more difficult. They won't come off as easily. So therefore, we require a larger decrease in PO2 to remove the oxygen. Now, this here gives an example of 80 millimeters of mercury, which kind of helps you with the question, because we talked about when you go from 100% saturation to 75% saturation, where you lose one oxygen molecule, you have a drop of 60 millimeters of mercury. Here, they're saying you need a drop of 80 millimeters of mercury to release that first oxygen. So it's binding tighter. It takes a larger effect or force, in other words, a lower oxygen partial pressure, to allow that to release. This would occur at the lung where we're binding, and this is dissociation. So when you're competing at the binding sites for when it's the exposure of the hemoglobin to carbon monoxide and oxygen, carbon monoxide will compete more readily. And remember, your venous return already has 75% oxygen still bound to it. So now if it's exposed to carbon monoxide, as I mentioned, the oxygen is actually going on and off at a particular rate. Carbon monoxide will compete with that and bind. But as we go to the circulation, and now we're talking about dissociation of oxygen as we're consuming oxygen, it will come off harder. Okay, so they're kind of two different sites. Any other questions? All right. 19. Which of the following statements regarding carbon dioxide transport is false? Hydrogen ion dissociates from hemoglobin as blood passes through the pulmonary capillaries. Remember, when carbon dioxide binds to hemoglobin or goes into red blood cells and we form bicarbonate, a hydrogen ion binds to the hemoglobin, but when we release that CO2, it's in reverse. So then the hydrogen ion dissociates from the hemoglobin, goes back, binds to the bicarbonate, forming carbonic acid back to CO2 and water. Okay, so make sure you understand that mechanism, that pathway, that equation of CO2 moving to bicarbonate. Make sure you understand all the steps involved in that. As well, most of the bicarbonate ion is formed in the red blood cells. That's true. That's formed in the red blood cells. It is not transported in the red blood cells, but it is formed in the red blood cells. Blood pH decreases as blood moves through the systemic capillaries. pH decreases because we're producing CO2. As CO2 is converted to bicarbonate, we get the hydrogen ion, which decreases pH. Okay, so make sure you understand the relationship of pH and hydrogen ions in relation to CO2. The normal concentration of CO2, and see, I couldn't quite read this. Either way, the difference always equals to the arterial oxygen minus the concentration. I really didn't understand this answer because it was all messed up here. So even though they say that's a correct answer, the important thing to know is these are the incorrect answers. In other words, but these are all true. So CO2 dissolved in blood is greater than the dissolved oxygen. And we said that. That's 7% of CO2 dissolves in the blood, where less than 2% of oxygen does. Okay, so even though I don't understand that answer, these other four answers are true. Like I said, I didn't write this exam and want to convert it over. It messed up some of the figures. Number 20, given the following information, calculate the alveolar ventilation. Make sure you can do the calculations between alveolar ventilation, total pulmonary ventilation, dead space ventilation. Make sure you understand what that is. This is fairly straightforward. Now keep in mind that we mentioned that body weight is relative to anatomical dead space. So 200 pounds is relative to 200 ml of dead space in your conducting airway. All right? So that's your dead space volume indicator. So to calculate this, we want to know alveolar ventilation. So to do that, we need to figure out what tidal volume is. So we take our total lung capacity, subtract inspiratory reserve volume and FRC, and that will give us tidal volume. So I believe that is 1 liter. So you take 1 liter, which is our tidal volume, minus our dead space volume, which is 200 ml. So now we have 800 ml, or 0.8 liters. So 0.8 liters is our alveolar volume, and therefore, with knowing our minute ventilation, will give us an alveolar ventilation of 8 liters. All right. Make sure you can do those calculations. Here, this was just to calculate the tidal volume. Then you use the tidal volume, and you have your dead space volume. And from that, you can calculate your rate and then your alveolar ventilation. All right, so make sure you can do those calculations very simply. There will be no calculators, so most of the math will be very simple. I won't make it too difficult as far as fractions or odd numbers. They will be fairly normal numbers. Now, in the next section, these are all true-false answers. There will be some true-false on your exam. Makes it simpler, quicker for you. However, make sure you understand that when you're looking at this, A, if all parts of the question are true, B, if any part is false. So you have to look at the entire question and make sure everything is true for it to be true. Okay, in a person with emphysema, airway resistance is greater during inspiration than during expiration. Okay, that's false. We talked about how resistance becomes an issue only during expiration primarily, not inspiration. If total lung capacity increases and vital capacity decreases, then residual volume must increase. Okay? Once again, look at be able to draw your volumes and capacities waves. Okay? Draw it out, label it. So if you look at that, you can see that your total lung capacity, if that increases and vital capacity decreases, well, you can see that the residual volume must increase. I mean, just look at the table. When you look at that, it's very straightforward. So make sure you can draw it, label it, because you're going to need it in probably more than one question on the exam anyway. So make sure you understand the relationship between the volumes and capacities and can do those calculations straightforward. 23, at residual volume, the recoil force of the chest wall is greater than the recoil force of the lung. Remember, at residual volume, that's the smallest lung volume that we can get to. That's when lung force is minimal. Okay? So the smaller the volume in the lung, the less recoil force. Okay? So that's easy to understand. So if that's at a minimum, we also know, if you think about it, compress that volume down to a residual volume. What are you doing to the chest wall? You're hugely compressing the chest cavity. Therefore, you have a huge recoil force on the chest wall. So obviously, the force on the lung is much greater than that of the chest wall. 24, an opening between the right and left atria, an atrial septal defect, causes an intrapulmonary shunt. Now, that's false, and what part of that's false? Okay, first of all, an atrial septal defect is a shunt, but it's an extrapulmonary shunt. Okay? Remember, intrapulmonary means within the lung. An atrial septal defect is in the heart. Okay? The heart is not in the lung. Make sure you know the difference. Intrapulmonary, extrapulmonary. Okay? Intrapulmonary, we're talking about our alveolar shunts. All right? Those in which we have no gas flow to that region of the lung, but we do have blood flow. Okay? So that's an intrapulmonary shunt. The FEV1 to FVC ratio is always less than normal in a person with pulmonary fibrosis. Okay? Forced expiratory volume in 1 second. Now, automatically, you know, if we're dealing with volumes and forced vital capacity, first of all, we can't get a normal volume. Therefore, we're not going to be able to force out a volume, all right, normally anyway. So that is false. Okay, so if anything, this is going to be greater than, because the forced vital capacity is going to be very small. Okay, so if the forced vital capacity is extremely small, that's going to make the ratio larger. So we have a large ratio because of our volume, total volume being small. 26, sensory receptors in the lung and chest wall regulate the tidal volume and frequency of breathing to minimize the work of breathing for any given workload. Okay, so work of breathing is optimized at a specific tidal volume and respiratory rate. Remember the curve we looked at when we looked at work of breathing? Your physiology determines what's the optimum to minimize work of breathing and to optimize your respiratory rate and your tidal volume. So that's why normally we have a tidal volume of 500 ml and a rate of about 12. So those are sensory receptors in the chest wall. We talked about those in the lung for volume, as well as chest wall. And also a lot of these receptors we're talking about are also your receptors for central chemoreceptors and peripheral chemoreceptors, as well as volume receptors. So all of those work to minimize the work of breathing under normal, healthy conditions. In a person with emphysema, both a decrease in the number of pulmonary capillaries and blockage of small airways increases pulmonary vascular resistance. That is true. So because we have a decrease in number of pulmonary capillaries, we also decrease the amount of oxygenation, causing pulmonary vascular or hypoxic pulmonary vasoconstriction, which causes an increase in pulmonary vascular resistance, as well as we have blockage of small airways. Remember, we have a lot of mucus secretion, mucus plugging, also in emphysema, as we mentioned, because emphysema is also considered a chronic obstructive pulmonary disease in which that occurs. 28, prolonged exposure to a decrease. Oops, I'm not even sure what that is. Decrease in oxygen at altitude. Okay. Anyway, a decrease in oxygen at altitude will cause the content of O2 in the blood to increase primarily due to an increase in the amount of dissolved oxygen. Well, we know we're decreasing the amount of dissolved oxygen. We're decreasing content. But it does say prolonged exposure to a decreased oxygen. So this is still false, because what happens is prolonged exposure to a decreased FiO2 at altitude will cause the content of oxygen to not increase, but it will move toward normal. So it will still be below normal. And so remember that even with compensation, it moves toward normal, but will not get there, because we can't produce enough extra hemoglobin, because if we did, our blood would become so thick and dense, it wouldn't circulate. But it does move in the direction to help facilitate oxygenation, oxygen transport. 29, both shunt and alveolar dead space can occur in the lung at the same time and cause a decrease in PaO2. That is true. And we said under normal conditions, because of the gravity dependence, we actually create alveolar dead space and intrapulmonary shunts to a degree within the lung in different regions all at the same time. But as we recruit that all up, all of that goes away. So the dead space goes away, the shunt goes away, and we utilize more of the volume for blood flow as well as airflow. 30, during an inspiration, most of the air will enter the bottom of the lung because it has more recoil pressure than the top of the lung. That's false. Okay, so during inspiration, most of the air will enter the bottom of the lung. We did mention that. So that part of it's true. But not because it has more recoil pressure. If anything, that would decrease the amount of air that went into it, because it's recoil pressure is we go to the bottom of the lung because we have less resistance there, not less recoil pressure. 31, the driving pressure of oxygen across the end of the pulmonary capillary is 60 millimeters of mercury. Remember, at the end of the pulmonary capillary, the oxygen is about 100 millimeters of mercury. Because by the time you get to the end, we have equilibration. And unless it says otherwise, always assume under normal conditions, a normal, healthy person. 32, in a person with anemia who has half the amount of normal hemoglobin, the saturation of hemoglobin in the arterial blood will be half of normal. So if you have half the amount of hemoglobin, that's going to change the oxygen content to half, but it is not going to change the saturation. Saturation will still be the same. So we can still be 100% saturated, but we have half the content. Okay, so make sure you understand the difference between partial pressure of oxygen in the arterial circulation as well as content. Content is regulated by the number of binding sites on hemoglobin, and the saturation of that hemoglobin, and partial pressure is purely nothing more than what's dissolved in the plasma. Once again, is less than 2% of total content. So they have different components. However, partial pressure is regulatory on saturation up to 100%. So we can't go above 100%, so even if we increase the partial pressure above that, we can't change it. So 33, the driving pressure for CO2 across the lung is about 10% of that for oxygen at the end of the pulmonary capillaries because CO2 is more soluble than oxygen in the alveolar capillary membrane. It is about 10% of that of oxygen. Now think about when we're talking about driving pressure. Driving pressure is nothing more than pressure differential. The partial pressure of CO2 in the venous blood coming back to the lungs is about 46. Partial pressure in the alveoli is 40. So our driving pressure is 6 millimeters of mercury. Oxygen, when it comes back from the venous circulation, partial pressure is 40. And in the alveoli, the partial pressure is 100. Driving pressure, 60 millimeters of mercury. Therefore, CO2 is 10% of oxygen. Okay? And that's because of the difference, not because of the solubility, that CO2 is more soluble than oxygen. That is not the driving pressure. When a person returns to sea level after living at high altitude for 2 months, so this is what we just talked about earlier, the arterial concentration of oxygen will be less than normal. Okay? That is false because immediately, as I said, your saturation comes back to normal. And content, if anything, will be higher because what happens is we're living at high altitude. That means we adapted. We made more hemoglobin, so to carry more oxygen. And now we go back to normal altitude. So now we have more hemoglobin and we have a normal oxygen. So now we have a higher content. And this is what we talked about when we said that athletes will go to altitudes to train. So just for this reason, they can build up the amount of hemoglobin in their blood. It actually helps condition the metabolism of their muscles. But primarily also, it is increasing the hemoglobin, so therefore when they go back to a normal altitude, they have more oxygen carrying capacity. So that will be more than normal, not less. 35, the flat portion of the O2 dissociation curve allows a person to function reasonably well at altitudes up to 10,000 feet. That is true, because if you look at the oxygen dissociation curve, it's where we're at the top end where it's kind of flat. It does not drop off very quickly. So if you look at 100 millimeters of mercury under, that would be our normal at sea level, for instance. Now if we go to altitude, our partial pressure of oxygen drops. But you can see that our saturation doesn't change much as we drop that first 40 millimeters of mercury or so. So our body has a capacity to not be affected much by altitude, even though it will some, because it is a curve and it is coming down. So there is effect no matter, as you increase altitude. But we certainly do not have a large effect. So these mountain climbers really don't have an issue with hypoxia until they reach much higher altitudes, typically greater than 10,000 feet, even though there will be an effect even at 5,000 feet or 1,000 feet. All right? So here we're saying that we have a reasonably well at various altitudes. So make sure you know there is a difference, but our body has a ability to compensate to some degree. Any other questions? Good luck on the exam. And if you have any questions, you can email them to me, and I will try to get to them.
35, I didn't quite get it. Can you just Say it again.
Oh, 35. That's when we, if you look at the oxygen dissociation curve, let's see, I think we have one here. We have one here. Nope, don't have one there. Anyway, an oxygen dissociation curve.
Okay.
You know what it looks like? It's fairly flat at the top, and then as we decrease the oxygen, then it sharply starts to come down for saturation. So if you go to altitude, and you can do the calculations on this, 10,000 feet, what your barometric pressure is, so you can actually calculate the partial pressure of oxygen. And even at 10,000 feet, we're still on the flat part of the curve before it starts to drop off and become very steep. So we still have a very high percentage of saturation even at 10,000 feet.
Okay.
Even though it's decreasing, it's still fairly high.
Okay.
And remember, we only used 25% or 1 oxygen out of 4 under normal conditions. So we have plenty of room. So if we are 100% saturated at 10,000 feet, we're still good because it is still high enough.
All right.